Hello everyone, welcome back to Mated Mastery. Today, we're diving into an important nephrology topic, membranous nephropathy. This is one of the most common causes of nephrotic syndrome in adults, and understanding its pathophysiology, causes, and management is crucial for both exams and clinical practice. So, let's break it down step by step. Membranous nephropathy is also called membranous glomerulonephritis. It is the most common cause of nephrotic syndrome in adults, particularly in individuals of European, Middle Eastern, or North African descent. This makes it an important condition to recognize, especially in these populations. Now, let's talk about the causes of membranous nephropathy. Primary membranous nephropathy is mostly idiopathic, meaning no clear cause is identified. However, research suggests an association with certain human leukocyte antigen alleles, particularly HLA-DQ-AE1. Secondary membranous nephropathy occurs due to underlying conditions, including infections, such as hepatitis B, hepatitis C, malaria, and syphilis. Autoimmune diseases, most notably systemic lupus erythematosus, SLE, malignancies, like lung cancer and prostate cancer, medications, including NSAIDs, penicillamine, and gold compounds. These secondary causes are crucial to identify because treating the underlying condition can help manage the nephropathy itself. Now, let's break down the pathophysiology of membranous nephropathy. This condition is caused by antibodies, often autoantibodies, that target antigens expressed on the surface of podocytes. One of the key antigens involved is M-type phospholipase A2 receptor, which plays a major role in primary membranous nephropathy. As these immune complexes deposit along the glomerular basement membrane, GBM, they trigger inflammation. This leads to increased permeability of the membrane, causing protein loss in the urine, a hallmark of nephrotic syndrome. The GBM is damaged by immune complex deposits that are sandwiched between podocytes and the basement membrane, specifically in a subepithelial location. These immune complex deposits trigger a chain reaction, activating the complement system. This activation leads to the formation of the membrane attack complex, which in turn damages podocytes and mesangial cells. This disruption increases glomerular permeability, allowing proteins like albumin to leak into the urine, ultimately leading to nephrotic syndrome. The immune response in membranous nephropathy doesn't end with the deposition of immune complexes. These deposits activate the complement system, leading to the formation of the membrane attack complex, which damages podocytes and mesangial cells. In addition, this immune activity recruits inflammatory cells that release proteases and reactive oxygen species, further injuring the glomerular basement membrane. As the structural integrity of the membrane deteriorates, it becomes more permeable, allowing proteins to leak into the urine, resulting in nephrotic syndrome. Importantly, the immune complexes involved can either form in situ, directly within the kidney, or be pre-formed in the systemic circulation, and then deposited in the glomerulus. Patients with membranous nephropathy typically present with features of nephrotic syndrome. The hallmark finding is proteinuria exceeding 3.5 grams per day, which leads to hypoalbuminemia due to the loss of albumin in the urine. This drop in oncotic pressure results in edema, often seen in the periorbital area and lower limbs. The liver responds to the hypoalbuminemia by increasing lipoprotein synthesis, leading to hyperlipidemia. While blood pressure is often normal, hypertension may occur in some cases, especially as the disease progresses. Clinically, membranous nephropathy may present with severe anosarca, a generalized and profound form of edema. Among all causes of nephrotic syndrome, it carries the highest risk of thrombotic complications, likely due to the marked loss of antithrombotic proteins such as antithrombin 3 in the urine. The disease course is variable. Around 1/3 of patients with idiopathic membranous nephropathy experience spontaneous remission. Another 1/3 remain persistently nephrotic, and the remaining 1/3 progress to chronic kidney disease. Early identification and risk stratification are therefore crucial for guiding treatment and monitoring. We can diagnose membranous nephropathy with a kidney biopsy. On light microscopy, there is diffuse thickening of the glomerular basement membrane. Electron microscopy shows the classic spike and dome appearance, caused by subepithelial immune complex deposits. Immunofluorescence reveals granular deposits of IgG and C3 along the glomerular basement membrane. Complications of membranous nephropathy include a high risk of thromboembolic events, such as deep vein thrombosis or renal vein thrombosis. This happens because important anticoagulant proteins like antithrombin 3 are lost in the urine. In some patients, the disease can also progress to chronic kidney disease, although this usually happens slowly over time. Regular monitoring and early treatment are key to preventing these complications. Management of membranous nephropathy begins with renin-angiotensin-aldosterone system inhibition, using angiotensin-converting enzyme inhibitors or angiotensin to receptor blockers as first-line therapy. These medications help reduce proteinuria and protect kidney function in cases where proteinuria remains high or the disease is more severe. Immunosuppressive therapy is added. Common options include corticosteroids, calcineurin inhibitors such as cyclosporine or tacrolimus, and cyclophosphamide. The treatment approach is tailored based on the severity of the disease, risk of progression, and the patient's response to initial treatment. Thank you so much for watching. I hope this video helped you understand membranous nephropathy in a clear and simple way. If you found it useful, don't forget to like, share, and subscribe to Mated Mastery for more high-yield medical content.